Okay. Hello, all of you. Hello, are you guys here? Hello.
Yes, yes.
Yes, yes.
Okay. So let's start discussing SLE. Okay. So for example, let's suppose like this is your keratinocyte simply, okay? Your skin surface. You you guys know whenever the sunlight hits your keratinocytes, right? They're going to undergo apoptosis. For example, if the nuclear component inside these cells are destroyed via UV rays, they are going to die, right? Hello?
Yes.
Hello?
Yes,
Yes.
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 Okay.
Yes, yes.
So they are
yes.
going to die. They are going to undergo apoptosis, right? So when these cells die off, you know IgG is going to come. They are going to opsonize these cells, right? And then your complement system is going to destroy them, right? But for example, if these, okay, so what happens? Your IgG is going to come. They are going to tag them, or you are going to see some antibodies against these apoptotic dead keratinocyte, right?
Hmm.
Okay, so for example, if a person complement, okay, isn't working, as you guys told me that in SLE you are going to have complement deficiency, early complement deficiency. It means the complement system isn't working well, right?
Right.
Okay, so it means that these IgG bound to these apoptotic bodies would rise because it's the role of complement system in order to eat this complex, right? Okay, so if we do not have complement system in order to eat off this complex, it means this complex is going to increase in quantity, right? Hello.
Yes.
Okay, if
Yes.
it's increasing, so it basically IgG against your own body cells simply, okay, that apoptotic, let's suppose, cell. So if we do not have complement system, it means they would rise in their quantity. They would come out in your blood simply. They would deposit in various tissues. Okay,
Hmm.
and inside those tissues, again, you are going to see complement system activation. Okay, and at this time you are going to see exaggerated activation of your complement system. But the complement system cannot eat these antigen antibodies complexes, but they would start eating up your normal body tissues. For example,
Okay.
if these antigen antibody complex, like this is an antibody and this is an antigen in this case, if these antigen antibodies complex go there deposit in your skin, it means in the skin you are going to see exaggerated activation of your complement system. It can't attack, it can't eat up these IgG and antibody complexes, but it would eat some of tissue over your skin. So you are going to see malar rash, right? For example, if these antigen and antibodies complexes deposit in your renal system, it means your complement system is again going to be activated, and as a result of that, you are going to see destruction of your kidneys, right? Hello.
Yes.
So, can you guys tell me whenever you have antigen antibodies deposition in various parts of your bodies, what's that? What's the example of hypersensitivity? What's the name of that hypersensitivity? Perfect. It's basically type 3 hypersensitivity. Okay. So you are going to see involvement of various organs, which we'll be discussing in details. Okay. For example, if you are, we will also be forming some antibodies against your red blood cells. Okay, and it would be directly attacking your red blood cells and killing them off. Can you just tell me its example of which hypersensitivity? Direct destruction.
2.
Yes, it's true. So remember, in SLE, you are going to see both type 2 and type 3 hypersensitivity, right? Okay.
Yes.
Okay. So, first of all, like this pathology is basically associated with your immune cells, yeah, or your immunity, right? So you are going to see some constitutional symptoms. For example, you would be seeing fever. You are going to see weight loss. Okay. So, for example, if these antigen antibody complexes deposit in your skin, they are going to give you butterfly rash, right?
Yes.
Why? You guys know. Yes, they can also go into your joints and they can cause destruction of your joints. That is arthritis. Okay, they can get into the serosal surfaces, one of which we have discussed in pericarditis. We were discussing that one of the cause of pericarditis can be SLE, and there I just told you guys you are going to see type 3 hypersensitivity antigen antibody complexes depositing in the pericardium and ultimately destruction by complement system, so you can get pericarditis, right?
Yes.
Okay, it can also just go to your CNS, giving signs and symptoms of psychosis. It can go to your renal system. Already we have discussed in renal system. Glomerulonephritis, guys, remembered?
Yes.
Okay, so it's going to give you diffuse proliferative glomerulonephritis. So can you guys tell me that the most common cause of death in patient with systemic lupus erythematosus is due to which system involvement?
Renal.
Yes.
Renal, perfect. So renal system involvement, it is the most common cause of death in patient with SLE. Okay. Okay. So here we are discussing. You are discussing that you are going to see antibodies against some antigen. Let's be specific. So you are going to see IgA against which antigens? Against your DNA, right? Hello,
Yes.
guys. I think you guys are feeling quite low. What happened? I'm not getting that enthusiastic response from you guys. Hello.
Yeah, we are here.
Okay. So your renal system is going to be involved. Secondly, we discussed that you are going to see Liebman-Sack endocarditis. What's Liebman-Sack endocarditis? Remembered? In cardiology, we have discussed Liebman-Sack endocarditis. Guys, yes, like in SLE, you are going to see an hypercoagulable state, which we will be discussing the anti-phospholipid antibody syndrome, in which you are going to see hypercoagulation. And as a result of that, you can see vegetation that are made of fewer platelets and fibrins on both sides of your valve. And that is basically your Liebman-Sack endocarditis on your mitral valve, right? So you can also see endocarditis. Okay, you are also going to see anemia, as we have already discussed, due to type 2 hypersensitivity, direct destruction of your red blood cells. You can see direct destruction of your platelets as well, thrombocytopenia, leukopenia, direct destruction of your white blood cells, leukocyte, right? So you were discussing that you are going to see anti DNA antibody, right? So this is highly specific. Anti DNA antibodies are highly specific for your SLE patients. Hello.
Yes.
You can also have drug induced SLE. We have discussed those drugs while we were doing cardiology. What are those drugs who can cause drug induced SLE?
Procainamide, drugs.
Procainamide,
Hydrolazine and procainamide.
isoniazid,
Okay, hydralazine, isoniazid,
isoniazid,
and procainamide.
procainamide.
Okay, so in case remember, it is one of your UWorld MCQ. So in drug-induced lupus, you like sometimes you won't be seeing anti-DNase antibodies. You are going to see antihistones antibodies. What are antihistones? You know, inside your DNA, you have certain proteins that are known as histones. So it's simpler. Simple. The antibodies would be against those histones simply. So it's very highly specific for your drug-induced systemic lupus erythematosus, right? Okay. You are also going to see certain antibodies against certain phospholipids. Okay. So antibodies against phospholipids. And those, okay, how? Like for example, these are your phospholipids. Like for example, present on the surface of your cell. You know, the protein is basically bonded to your phospholipids. So these antibodies would be against the protein which binds to phospholipids. Remember that, okay? And sometimes, okay, so you are going to see an anti-phospholipid antibodies, right? You can also see anti-cardiolipin antibodies. Okay. So sometimes you can also have an hypercoagulable state. Okay. whenever you have antiphospholipid combined with hypercoagulation, that is basically known as antiphospholipid antibody syndrome, right? So in that case, you are going to see hypercoagulation everywhere inside your body. For example, if you have hypercoagulation, it means there is increased chances for formation of thrombus, right?
Yes.
Yeah.
Okay. For example, if this thrombus happens in the, let's suppose, hepatic vein, what's that condition called?
But
Budd-Chiari
Chiari
syndrome.
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 Yes, but Chiari syndrome. Yes, you can also have DVTs, right? Because of this
Yes.
hypercoagulable state. Simply, so these patients are basically put on lifelong anticoagulants. So, I think it was enough for today. And let me give you guys some homework. You guys are going to do the remaining pathologies, that is Sjogren syndrome and your scleroderma. Tomorrow we are going to discuss them. But till now, I think it was enough. So let's have revision of all of these. What do you guys think?
Mm.
Do you guys want to revise the immunity?
Yes, yes.
Yes,
Okay.
yes.
Yes, sir. We want to revise.
Okay. So I will be starting from the first lecture. You guys are only going to listen. Okay. So I'll be okay asking from each and every person here. Okay. First of all, Dr. Crownich, I guess. Kindly, can you turn on your mic? All of the guys, you can just turn off your mic. Dr. Crownich is going to answer me. Hello.
Yeah, hello, Dr. Ahmed.
Okay. Hello. So we are
Uh,
going to have a revision of entire immunology. So you are going to. I'm going to ask you some simple questions. You are going to tell me.
okay.
We have two type of lymphoid tissues, right?
Yeah,
Primary and secondary, right?
yeah.
Can you just name two of the primary lymphoid tissues?
T helper and T.
Okay,
Um.
I'm asking about tissue. That is your bone marrow and thymus, right?
Oh, okay.
Okay. So the bone marrow is going to produce which cells?
Bone marrow produces erythropoietic cells.
Okay. That is
Yes.
thymus is present in your anterior mediastinum. Okay.
Yeah.
So we have some secondary lymphoid tissues as well. That is spleen, lymph
Yeah.
node, fire
Yeah.
patches, right?
Yeah.
Okay. So it was all for you. Thank you, doctor. Dr.
Thank you.
Zainab, can you kindly turn on your mic?
Yeah.
Okay. So can you just tell me the lineages that come out of your hematopoietic stem cells? There are two lineages. Can you just tell me
Yes.
each and every cell?
Lymphoid in myeloid.
Okay.
B cells, lymphocytes come of lymphoid lineage, and
Okay.
natural killer cell as well. B lymphocyte, T lymphocyte, and from
Okay. B
red
cells are going
lineage,
to convert into which kind of cells?
plasma cell and secrete antibodies.
Perfect. T cells.
T cells also from lymphoid lineage.
Okay. They are going to convert. You have different types of T cells. What are that?
Yes, T helper cell and cytotoxic T cell.
Okay. T helper cells. You have further two types of T helper cells.
Th1, Th2.
Th1 is going to drive which reaction?
Granuloma formation,
Okay. That involves which cells?
macrophages.
Macrophages. Perfect. Okay, guys, please listen to it. Okay, we are going to revise each and everything. Okay, then you have cytotoxic, then you have Th2 response, right? Th2 response is going to activate which kind of cells?
B cells.
B
B
cells,
cell.
perfect. Okay, for intracellular organism, we need Th1 response or Th2 response?
Th1
Th1
response.
response.
Okay, Dr. Zainab only. Okay, for extracellular pathogen, Th1 response, Th2 response.
H2 because of antibody production.
Perfect. So can you just tell me the myeloid lineage as well?
Yes. RBC.
Okay.
Um, thrombocytosis.
Okay. Platelets,
Megakaryocytes come of that.
megakaryocyte,
Yes.
perfect.
In
that we have a pathology in which you are going to see no thymus. What's that?
It's Dijor syndrome,
Okay, perfect.
in which there
So
will be thymic aplasia along with hypercalcemia and cardiac defects.
yes, cardiac defect, KOF. Okay. So can you just tell me another pathology that is related with like antibodies being released from a thymoma? What's that?
It's myasthenia gravis. Thymoma is
Perfect.
associated with
Perfect.
myasthenia gravis.
Okay, perfect. So thank you, doctor. Now
Thank
let's
you.
okay, Doctor Salma. Can you turn on your mic? Hello. No response from Dr. Salma. Okay, Dr. Maheen. Can you please turn on your mic? Hello. Okay, Dr. Talia, please turn on your mic. Okay,
Yes,
thank you.
can you hear me?
Yes, I can hear you. Okay, can you just tell us about spleen? What's spleen? And you have two parts of spleen. Which kind of cells are present in which kind of okay, all of that?
I think it has red pulp and white pulp.
Okay, which kind of cells are present in your white pulp?
T cells
Yes, where specifically the T cells are present?
inside the spleen.
Okay, inside the spleen are in the periphery of this artery or periarteriolic spleen, right?
Yes, periarterial.
Okay, the B cells are present inside the white pulp, specifically where?
Uh, on the periphery of the
Follicles,
arteriole.
follicles,
Okay.
follicles. Remember?
Yes.
No. Okay.
Yes. Yes.
So, can you just tell me that, for example, if a person had undergone splenectomy, he is prone to encapsulated bacterial infections. Why?
Because uh, spleen, I think it plays a role in the formation of plasma cell and antibodies, which
Yes,
destroy
perfect.
the encapsulated
Perfect.
bugs or. So if
Okay.
it's not present, then there is no destruction to that type of a bugs, and it can lead to various infections.
Perfect. So, can you just tell me that in heredity spherocytosis,
They lead to destruction of the RBCs. In them, they become sphere shaped, and then they are easily to get destroyed.
okay, in which pulp?
Hereditary
White pulp or red pulp?
red
Okay, perfect. Red pulp. So,
sequestration of RBCs occur over
yes,
there
perfect.
too
Okay.
after like every 120 days.
Thank you, Dr. Talia. So, Dr. Amna, can you just turn on your mic? Hello? Dr. Amina. Hello? Okay, Dr. Rafiq. Hello?
Yes.
Okay, thank you. So, can you just tell us the different parts of your lymph nodes, the cortex, the paracortex, the medulla, and which kind of cells are associated with that?
Yeah, the cortex is related with the B cells, and
Okay,
paracortex, it is for the T
T
cell
cells. So,
maturation.
okay, cortex have primary follicles and secondary follicles. In the
Yeah,
primary follicles, which kind of B cells are present?
inactivated, like
Inactivated,
it's
dormant.
for
Perfect.
storage.
Okay,
And
perfect. Secondary
and the
follicles.
secondary follicle, it's for germinal follicle, like it's
Okay.
activated.
So, what do activated B cells mean? That they would be having isotype switching. They
Yeah,
would be
isotype
switching amyl.
switching and
Okay,
plasma B cells
perfect.
are also forming in this.
Okay, so for example, if a person is having some viral infection, we are going to see hyperplasia of which part of the lymph node?
It's cortex,
T
like
cells.
it's
Perfect.
T cells,
Okay.
like cytotoxic T cells are
Okay.
related with the virus
Okay. Thank
and
you. So,
fungi.
okay. So now, Dr. Rafiq, let's discuss innate immunity. Can you just tell me, is it specific or not?
It's not specific. It's
What's
like
what about the
neutrophils.
speed? Yes, it's fast or slow.
It's very rapid, and the
Okay.
second response is also the same one.
It's same. Perfect. So, okay,
Yeah,
can you just
and
tell me this? Okay, no
no
memory.
memory in
Perfect.
that. Yeah,
Perfect. So, can you
and the
just tell me the
cells.
receptors associated with these cells? They are
The cells are neutrophils, macrophages,
Okay, perfect.
monocytes, dendritic cells, and
Okay.
B cells also, complements.
Okay, perfect. So basically, the toll-like receptor is associated with it. It's
Yeah.
going to recognize PAMP, pathogen associated.
Yes.
Okay, perfect.
And they activate the NFKB,
Yes, it
and
would
then
activate NFKB.
transcription.
Okay,
Transcription occurs inside the DNA,
okay,
and then I forgot.
okay, no problem. Thank you. Dr. Ramesh, can you just tell us about adaptive immune system? Is it specific or speed, slow or fast?
It's slow.
Okay, so the future response would be heightened or not as
Heightened.
compared to. Okay, perfect. So do they have memory?
Yes.
Okay, so can you just tell me the components which cells are present in your, which cells are associated with your adaptive immunity?
T lymphocytes, B lymphocytes,
Okay,
uh,
perfect.
antigen presenting cells,
Okay, perfect.
and antigen presenting cells like dendritic cells,
Yes,
macrophages.
dendritic cells, macrophages, monocytes, B cells. Okay, thank you, Dr. Ramesh. Dr. Barmet, can you kindly turn on your mic? Hello. Okay, Dr. Abhinaya, can you please turn on your mic? What happened, guys? Dr. Gabriel or Gabriel. Hello, please.
Hello.
Anyone? Okay, thank you. So, can you just tell us the whole phenomena that the antigen presenting cells do? How do it engulf a pathogen, and how do it? What does it do next?
Um, so once it identifies an antigen, it
Okay,
it
it's going to
releases a
engulf it, right?
substance that binds to it so that they could opsonize it. And
Okay.
then
First of all, antigen presenting cells are going to engulf a pathogen. Then it's going to present it on its surface receptor. What's the name of that receptor?
the Th2 cell.
Okay, that's MHC2,
Okay.
major histocompatibility 2. Then what happens? Your antigen presenting cells is going to present it to CD4 cells, the helper cells, right?
Right.
Okay, then you are going to see a co-stimulatory signal as well, B7 and 28. Remember?
I have to read it again, but okay.
Okay, okay. So, Dr. Renu, can you just kindly explain to Dr. Gabriel that what happens in antigen presentation and all of those stuff? Dr. Renu, hello? Hello?
Yes, sorry, Dr. Raman. Yes.
Okay, no issue. Can you just explain, Dr. Gabriel, that what's the, how do the antigen presenting cells basically work?
Okay, so antigen presenting cell, okay, they will present with MHC2 on their surface.
Okay,
Yeah, then the CD4 positive T cells will come.
okay,
Yeah, it will activate the T cells.
okay.
Then
And we also have a co-stimulatory receptor. What's the name
co
of that?
yeah, the co-stimulus stimulatory receptor is 4040 ligand.
Oh, no, it's
Oh,
B728,
sorry, sorry.
4044, B cell activation,
Sorry. Yeah, it is
alpha type switching.
B7 CD28.
Okay, perfect.
Yes,
So,
yes.
can you just tell me that MHC1 is going to bind to which kind of cells?
CD8
CD8 positive, cytotoxic
positive.
cells. Okay, those cells who do not have MHC1, which cells are going to come and attack and kill them?
Natural killer cells.
Natural killer cells. Perfect. Okay.
Yeah.
So thank you, Dr. Dr. KIZZY, Kizzy, I guess. Hello. Can you turn on your mic? Hello. Dr. Dr. Noor. Can you kindly turn on your mic? Noorul Mubin. Hello. Okay, Dr. Sahina, please. What's happening, guys? I think Dr. Futures is going to do a lot of work today. So, Dr. Futures, please. Okay, so can you kindly just tell us that? Okay, so it's antigen presentation. Just give me a second. Okay, can you just tell us about acute inflammation? What happens in acute inflammations? Oh yes, toll-like receptor, pathogen-associated molecular pattern, LPS. Okay, 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 okay. Can you just tell me the okay, just tell me about neutrophil migration. How do the neutrophil migration take place? Okay, perfect. And what's that step called? Perfect. Secondly, okay. Yes, rolling and which surface molecules are involved in? Yes, and E-select. Okay, then what happened? Yes, perfect. Yes, perfect. We stop them with adhesion molecule,
And then
right? ICAM, perfect. So then we have to migrate them, right? Yes. So what's that? Yes, transmigration. Okay, and which like receptors are involved in transmigration? PCAM, right? Okay, perfect. So Dr. Renu, again.
Yes,
Okay,
Dr.
can you just tell us that T cells are made inside? Just be quick, please.
Inside the bone marrow,
Matured in.
thymus,
Okay, in the thymus, they appear as a single positive cell or double positive cell
double
initially.
positive, 4 positive, 8
Okay,
positive.
then they are going to pass a test. What's the first? What's the name of
Positive
that first
selection.
test? What happens in positive selection?
Positive selection, CD4 strongly binding to MHC2 and CD8 strongly binding to MHC1.
Okay, if they do not bind well, what happens?
They are like apoptosed.
Okay, then you have negative selection, right?
Negative selection,
What
yes.
happens in negative selection?
Negative selection, we see if the T cells are binding strongly to the self antigens.
Okay,
So if they are binding strongly, like with higher affinity to the self antigens, so they are like apoptosed. They are like
okay,
eliminated.
okay. So if they, let's suppose, escape the, okay, what's the tolerance? What do we call it?
This is
Central
central
tolerance, right?
tolerance. This is
Perfect.
central
Okay.
tolerance.
What
Yes.
if the cell escape? Then
Yeah.
do
If
we
the
have a second
cells,
mechanism to protect our body?
yeah, if the cells escape, then they go to lymph nodes and like outside of the thymus.
Okay.
So
Then they
like
are going to attack your cell, the
uh,
peripheral tolerance.
yeah, that is peripheral tolerance.
Okay. So Dr. Zainab, hello.
Yeah.
Can you just tell us that what happens in peripheral tolerance?
In peripheral tolerance, there is CD28 and B7 receptors. If the interaction
Okay.
does not happen, because normally our body cell does not express B7, so
Okay.
there the cell cannot be destroyed.
Okay. Okay, good. So, Dr. Zainab, can you just tell us the structure of MHC1? MHC1 is present on which kind of cells?
All eukaryotic cells.
Perfect. So, can you just tell me that there is a microglobulin associated with MHC1 and relation with dialysis, amyloidosis, and all of that?
Yes, beta 2 microglobulins, because dialysis cannot clear. For this reason, this buildup will lead to dialysis-related amyloidosis.
Perfect. Okay. So, can you just tell me which kind of cells are going to attach to MHC1?
MHC1?
Yes. Cytotoxic CD8, right?
Yeah.
Okay. And for example, if the cells do not have CD8, natural killer cells are going to attack it, right?
Yeah.
Okay, then we have MSC2. Can you guys tell me that MSC2 is present on which kind of cells, Dr. Zainab?
Antigen presenting cell.
Okay, and they are going to come in contact with which cells? Once we
CD4.
just CD4 helpers. Perfect. Okay. So, okay, so now anyone, okay, Dr. L Futures again because no one is participating. So, Dr. L Futures, can you just tell us the different types of T helper cells, all the T cell lineage simply? Okay. T cells, Th1, Th2. Sorry, helper and killer. Helper have Th1, Th2. Can you just tell me that the responses associated with them? Okay, can you just tell me? Okay, your lymphoid lineage is going to give you T cells. Can you just tell me major types of T cells? Helper and killer, right? Okay, Th1, Th2. Th1 is going to drive granuloma formation, right? Th2, B cells response. Okay, now let's discuss B cells. Okay, Dr. L's futures. So B cells are made inside, matured inside.
Bone marrow.
Okay, good.
Nah.
Nice. Okay. Wow. You have just invented a new thing. Okay. So, can you just tell me the surface receptor associated with B cell is similar to that of IgG, right? Okay. And you also have MHC2 receptor on their surface because they can also act as antigen presenting cells, right? Okay. Once B cells are activated, they are going to convert it to which type of cells?
Plasma cells.
Plasma cells. Plasma
Yes.
cells are going to release. Okay. Can you, okay, Dr. Talia, can you just tell us the TH dependent B cell activation?
I think I don't remember. Sorry.
Okay, no problem. So, Dr. Renu, again, can you just tell me that the TH dependent activation of your B cells?
Yeah, so the TH dependent will be the same thing that I was saying earlier when the T cells are
Yes.
activated. There is this co-stimulatory signal of CD40 ligand.
Yes. For example, if we have some defect in CD40 ligand, can you just tell me the pathology associated with that?
Yeah, that is hyper IgM syndrome.
Okay, perfect.
Yeah.
So, can you just tell me what happens in TH independent activation of B cell? Okay, do we see memory in case of TH dependent B cell activation?
Yeah.
Yes,
Okay,
yes.
okay, and only peptides can activate it, right?
Yes.
Okay,
Peptides or
Doctor.
proteinaceous antigen. Yeah.
Okay, now only. Okay, Doctor Rameez, can you just tell me? Okay, okay, isotype switching. Okay, you have already. Okay, can you just tell me the antibody structure? There are two parts of antibodies.
Mm, there are two parts like FC and FAB and FC. That
Okay,
is what you're saying, right?
FC portion play important role in opsonization, right?
Yes,
Okay, FAB have variable regions which are highly
yes.
specific towards. Okay, so can you tell me that what's affinity maturation?
Affinity maturation is like once a certain antibody binds to a specific antigen, then those variants
Strongly, right?
those
Once they
variants
bind
strongly bind.
strongly. Okay,
Yes,
perfect.
once they bind
So can
strongly, then that specific variant gets hyper matured.
okay, perfect. Can you just tell us what is isotype switching quickly?
Uh, Once the specific antigen is presented by the antigen presenting cells, then they can induce different types of specific variant of the immunoglobulin to be formed by via
Yes.
like IgG, IgA, and IgG,
Okay. Can you just tell me the initial antibodies that is being formed by your B cells?
IgM.
IgM. Perfect. Okay. So now let's discuss each and every antibodies in detail. IgM.
IgM is a pentamer.
Okay,
and
perfect. It's joined with one another by which chain? What's the name of that chain?
JHN.
J chain. Perfect. Do they have higher affinity or higher avidity?
They have higher avidity but low affinity, I think.
Low affinity. Perfect. Okay, IgG, most abundant, right?
Yes,
According
and
to
it's a
Dr. Reno,
the
it was dimer, right?
dimer.
No, no, I made a mistake, Dr. Ahmed.
Okay, I'm just kidding. All of you guys are just sleeping. So, okay, IgG. Okay, IgG is a monomer, right?
Yes,
And it's
Yes.
going to give you the first 6 months of what? Immunity, right?
immunity because it
It
can
means
cross
it
placenta.
crosses placenta. Oh, perfect. Okay, IgA associated with which kind of
Mucosal
immunity?
immunity,
Perfect.
mucosal surface
So,
immunity,
okay,
and it is
IgE.
IgE is associated with type 1 hypersensitivity
Okay,
reaction.
perfect. Cross-linking, degranulation of mast
Cross,
cells. Perfect. Okay,
yes.
so now let's, Dr. L Futures, please come forward again. Okay, hello. Okay, so can you just tell us the different components of complement system, different pathways of complement system, how are they activated? Okay, what happens? Okay, 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 yes, okay, yes, okay, okay, perfect, okay, okay. C3b, C3a, and C3b. C3b is going to bind with a factor that is factor B, right? And it's going to form C3 convertase, right? And
No, that is for the
no, that's for
alternate.
alternate.
No,
Lectin, mannose binding,
Lectin is
MBL.
like the carbohydrate, the mannose. I mean, yeah.
Okay. So can you just tell me a pathology that is associated with DAF, paroxysmal nocturnal hemoglobinuria?
PNH.
P, PNH.
pH.
Okay. Okay. What happens in that?
In P, in
Yes. Okay. Okay. So
yes,
I'm
okay.
sorry, I forget one thing. So why DF can't be produced?
Okay. There's a
genetic defect.
mutation due to some, yes, GPI anchor protein which basically expresses your DAF, right? So if you have certain mutation in GPI anchor proteins, so DAF cannot be expressed on the
Okay.
surface. As a result of that, what happens? You are going to see overactivation of your complement system, simply. Okay. So now let's discuss. Okay, Dr. Ramesh, please.
Yes,
Can you just tell us what is G-George syndrome quickly?
it is the non-development of the thymus that, as a result, T cell maturation cannot happen.
Okay, perfect. What happens in severe combined immunodeficiency?
Here, there is defect in cytokine receptors and also complement receptors and accumulation of toxic metabolites
MHC2?
in oh
MHC2.
MSC2 receptors, sorry, and
Okay.
the accumulation of toxic metabolites in B cell and T cells. As a result,
Okay.
there is decreased quantity of B cells and T cells, and this can lead to decreased immunity, and these patients are prone to different type of infections and
Like viral,
life expectancy.
fungal, bacterial, protozoal, each and every. So what's the treatment? Just keep them in bubble, right? Sterile
uh,
isolation, or give them
and
stem cell.
stem cell
Stem cell.
transplant.
Okay, perfect. Dr. Talia, can you just tell us what is X-linked A gamma globulinemia?
I just forget about it.
Okay, no worries.
It's
Yes, Dr. Meduri.
Midori.
Can you just
Yeah.
okay?
It's just X-linked, and there is a deficiency of tyrosine kinase,
Perfect.
and there is a defect in B cells maturation,
Okay.
and there will be history of repeated respiratory tract infections.
Okay. Why? Because you aren't forming that IgA, right?
Yeah,
Okay.
and
No class
yeah,
switching.
no class switching.
Okay. Can we give them live vaccines?
No.
Okay. So we have another pathology that is common variable immunodeficiency. So what happens in common variable? We are going to see less levels of B cells and T cells, right? Less levels, not absent. Okay. Can you just tell us, Dr. Alfutures, what is what happens in IgA deficiency and what is IgM syndrome? Yes.
Diarrhea.
Okay. Viral infections, perfect. What happens in IgM syndrome?
Class switching doesn't occur in this
Yes, perfect. Due to
due to
defective
CD40,
40.
CD40
CD40,
ligand.
CD40 ligand. Perfect. So what happens consecutively? You are going to see low IgA,
Recurrent,
low IgG, low IgE. So you are going to see
recurrent
recurrent
infections
infection
as
on
well
the
as
mucosal.
mucosal infections.
Yes, perfect. So now let's discuss our SLE. So Dr. Meduri is going to tell us what's SLE. What's the basic concept of SLE and what happens in SLE?
SLE is a disorder of autoimmunity,
Yes. Which
and
kind of hypersensitivity are we going to see? There are two types.
it's type 3 in renal and type 2
Okay.
in
And type
skin.
2 in red
In
blood
skin.
cells, plasma. No. Type 3 everywhere, but type 2 in due to red blood cell
Okay, yeah,
destruction.
red blood cells. Yeah, sorry.
Yes. Platelet destruction, leukopenia, leukocyte destruction. Okay.
Yeah.
So okay, so can you just tell me that we are going to see which kind of antigen antibodies complexes? The antibodies would be against which component of your nucleus?
Histone, normally it's against anti-nuclear antibodies,
It's
but in
DNA.
DNA, yeah.
Yes.
And if it's drug-induced SLE, then it's against anti-histone antibodies.
Okay, can you just tell me the clinical features? Butterfly
Uh,
rash,
butterfly rash and
arthritis,
arthritis and renal involvement.
renal damage, most common cause of death, right?
Yeah.
Okay, endocarditis associated with SLE. What's the name of that?
Liebman-Sachs endocarditis, in
And
which
what's
both
specific
sides of
about
the
Lehman's? Both sides, perfect.
yeah
We are also going to see anemia, thrombocytopenia, leukopenia due to type 3 hypersensitivity or type 2.
type 2.
Okay, perfect. Can you just name the drugs that are included in that causes drug-induced SLE?
Yeah. Hydralazine, isoniazid, and
I'm talking
propanamide.
about. Okay, so what's antiphospholipid antibody syndrome?
It's an antibodies against antiphospholipids like cardiolipin,
Against the proteins which bound to phospholipids.
phospholipids.
Okay, so okay, we are going to see anticardiolipin. Basically, the anticardiolipin antibodies also rises during syphilis test, right? Whenever
Yes.
we are screening a person for syphilis, so we are going to see anticardiolipin. So basically, this can give us false positive syphilis test, right?
Yeah.
Okay, so antiphospholipid syndrome, antiphospholipids along with hypercoagulability is going to give you antiphospholipid antibody syndrome, right?
Syndrome.
You are going to
Yes.
see thrombosis everywhere. For example, deep vein thrombosis, hepatic vein thrombosis, okay, placental thrombosis, recurrent pregnancy loss, and ultimately it requires long life anticoagulation. So I think after this, you guys know the immunology. It was quite simple, guys. Okay, so here's your homework. You guys are okay. Just write it down. Tomorrow you guys must have done it. Okay, because tomorrow I'll although discuss these topics, but you guys have to do it. Okay, that is your Shogun syndrome, scleroderma. Just write it down, please. Hello.
Yes.
Yeah, we have.
Sjogren's syndrome, scleroderma, that is systemic sclerosis, hypersensitivities, hypersensitivities types, transplant rejections, and vaccinations. Right? Tomorrow I am going to discuss it. Don't worry about that. But you guys should know at least a little bit. Okay. So guys, so did you in? Okay, we have only all of the people have just escaped from the lecture. We only have. Okay. So hope so you guys enjoyed. So let's continue
Doctor,
tomorrow, and tomorrow would be our last. Okay. Yes.
yeah, doctor, can you just share the PDFs of this immunology? Then it will be very nice to
Okay.
verify
Basically,
something.
I'm just okay. Let me tell you guys, I'm doing it from first aid and pathology, mostly from pathoma. So you guys can just see that. Okay.
Okay. Okay.
Okay. So hope so you guys enjoyed, and
Okay.
thank you. See you tomorrow. Okay.
Yeah. Thank you,
See
Dr.
you.
Ahmed.
Well,
Thank you.
Thank you.
Thank you. Have a nice day. Thank you.
Thank you.
Thank you.